Cardiac question. Let's say you're treating a 48-year-old female with some crushing chest pain radiating down her left arm. You do a 12-lead EKG and you note some ST segment elevation in leads 2, 3, and AVF. Is this involving the A, right coronary artery, B, left anterior descending coronary artery? Is it C, the left circumflex artery? Or is it D, the posterior descending artery? Now we're looking at ST segment elevation in leads 2, 3, and AVF. Collectively, we call that the inferior wall. It's viewing the inferior wall of the heart. Now, the inferior wall of the heart often involves the right side of the heart and is supplied by A, the right coronary artery. The right coronary artery provides blood flow to that inferior wall in almost every patient. In 85% of people, it wraps around and provides blood flow to the posterior descending artery as well. And in about 15% of people, that posterior descending artery receives blood flow from this left circumflex artery. So the inferior wall is usually supplied by the right coronary artery. Additionally, some things you might see on the EKG is ST segment depression in the high lateral leads. That's leads 1 and AVL, especially AVL. Almost any time you see ST segment elevation in lead 3, you will see that reciprocal ST segment depression in AVL. That's because those two leads view the heart almost completely in opposite directions. You might also note some ST segment depression in leads V1, V2, and sometimes extending all the way to V3 and V4. Now that's not reciprocal to the inferior wall, that is reciprocal to the posterior wall. Because most people receive blood flow to their posterior descending artery from the right coronary artery, you may see an inferior wall MI with posterior wall involvement or posterior wall extension. Sometimes the first thing you see with a right coronary artery occlusion is that posterior reciprocal change, that ST segment depression in leads V1 and V2. It's pretty specific for the posterior wall. So you may see an inferior posterior wall MI with a right coronary artery occlusion. It's very common. You might also want to check for right ventricular involvement. Now, this isn't as important as we once thought because nitrate therapy is dangerous in almost every type of myocardial infarction that is mildly hypotense. However, the right ventricular infarction can be specifically preload dependent and may require some fluid administration. So traditionally, we would move leads V3 and V4 over to the right side of the chest of the patient and then redo a 12 lead and look at V3 and V4R. However, we now know that all you have to do is look at lead 3 and lead 2, and if you have more ST segment elevation in lead 3 than in lead 2, it is almost certainly involving the right ventricle. That's because lead 3 is positioned to the right of lead 2 and looks more to the right side of that inferior wall, which involves the right ventricle.